class a physical one or online?
It was a physical.
So people are still walking to their homes?
I think so, but the rest will catch up as we continue.
But your class has never been full because, and I was shocked because when you were doing the cut the other day, you were many, you were, I think, 40. And for me, the highest, when you do physical, I think we've only been 21. And online, I think we've only been 32. So I'm wondering where the others are coming from because now we have to sit down and look at our attendance. And then we will now not allow others to sit because, you have to attend class and 80%, if you look at the curriculum or the rules, I don't know, where are the others? Or where are they usually?
I'm not sure, madam.
Yeah, but you see, so these are the people who will be failing. I'm just wondering. Okay. We'll just start. It's a long class. It's going to be a bit long, and I know it's at the end of the day, but we will manage. I'll try to summarize some of the things. Okay. I hope you can see my screen.
Yes.
Okay. So we're going to be looking at disorders of the vulva, actually. Okay, female genital tract. I think maybe you already did the other one because now we missed some classes in December. So the female genital tract, of course, you look at the vulva, you look at the vagina, then you go to the uterus, and then you go to the fallopian tubes, and then the ovary. That's the female genital tract. So today we'll cover the vulva, the vagina, and then the uterus. And the uterus is divided into three. So for the vulva and vagina, not much. I'll just maybe have a few slides. And most of it is more of infections, which you have covered in your microbiology when you are doing especially the sexually transmitted infections. So, and not only those, even when you're looking at tropozoa, for example, in your or fungal in your microbiology, which you already covered some time back. So I'll just peruse through those so that, and then we'll take a lot of time on the cervix itself and endometrium, and then we finish with myometrium. Okay. So let's start with the outer part. So our learning objectives, again, we'll review the infections, which you've already covered in microbiology. And then you have to remember your anatomy and physiology of the female genital tract so that it becomes easy to understand. Then we'll deal a lot with the cancer of cervix, then the endometrial disorders, including the tumors, and then myometrium too. So we'll have covered all the way till the uterus. Then fallopian tubes and ovaries must have already been covered. Yeah. So infections, of course, this may involve the vulva, the vagina, okay, the cervix, then the uterus body, then it goes to the fallopian tubes, it goes to the ovaries, okay, and then it goes to the peritoneum. Okay, it spreads out, okay, through the tubes at the femoral end. Okay, so those are things that they happen. They can be sexually transmitted or can even be opportunistic infections or even endogenous infections. Sometimes it's you have something which is normal flora, and then because of your immunity changing, it becomes pathogenic. For example, the fungal Candida albicans. Okay, so that's what I mean by that. Then opportunistic infections also come in, especially when our immunity is affected. Okay. So, predisposing factors, of course, some of these infections are multiple sexual partners, especially for sexually transmitted disorders, including your HIV, HPV, herpes, etc. Then, poor genital hygiene, which lowers your immunity, pregnancy and postmortem, because the immunity already is affected, and the hormonal component that is included. Then, when you're having instrumentation, if you're not doing an aseptic technique, then infections would go in. Okay, the immunosuppression, as we mentioned. So the infections can either be acute or chronic. Of course, for any acute infection, just as we taught you in inflammation, we'll see more of the polymononuclear cells, which are the neutrophils. Okay, then of course there's edema, there's tissue damage. But as the infection now goes into the healing, you remember inflammation, then healing. So some of it may heal with scar formation or fibrosis. Okay, and this fibrosis and adhesions is what now gets like into the fallopian tubes. Then you have somebody developing infertility because the tubes have healed with a scar, with fibrosis or adhesions. Okay, yes, and that can spread even to the peritoneum. So this is just an intro that is something you've already covered. You did that in your microbiology, most of it, what I'm talking about. Okay, so the infections that you will get, bacterial infections, the ones that are sexually transmitted, you have your Neisseria, gonorrhea, and your chlamydia. Okay, then for the endogenous vaginal flora, normal flora that we find inside in the vagina, you have Gardnerella vaginalis, which causes a lot of the bacterial vaginosis. Then you have anaerobes like your Bacteroides, etc. Then you also have E. coli and strep. Okay, those are endogenous microorganisms. Then you may have specific microorganisms like TB. Like now, I'm trying to deal with a TB, which I think it's TB endometrium. So you can have those specific ones. But I see a lot of infections also, like TB, which will come as a tubovarian mass that you've already covered. So TB. And then, yes, Rachel? Rachel? Your mic is on. Is Rachel part of us?
Yes, I'm sorry.
Okay. So that is bacterial. So you see, we're talking about sexually, then those that are endogenous and those that are specific. Then viral, we have your HPV, you have your herpes type 2, and then we have HIV, which predisposes to the opportunistic infections. Fungal, we have Candida albicans, and then for the tropozoa, we have Trichomonas vaginalis. So we have all these infections that can affect the female genital tract. I think I'll not go into many details because you have covered it in microbiology. So I'll just talk about what we see if someone has the disease, which is morphology. So if it's in the vulva and the vagina, especially with Candida, they usually, when you look at the mucosa, it's erythematous, and then you have this cuddy white, like yogurt, that discharge. Okay. And then if you do microscopy, you'll see the pseudohyphae. Okay. Then for trichomonas, we usually say tricks in short. But so for the trichomonas, if you look at the vagina and the vulva, many times you'll see the punctate hemorrhages. They look like strawberry, yeah? And then for the bacterial vaginosis, especially on our pap smear, what we see is the clue cells. Clue cells is a squamous cell that has the small bacilli on top. Looks like a rug, that are on top. So we call those clue cells. So when I see that, I call it bacterial vaginosis. That I'm able to see even on a pap smear. Trichomonas, I'm also able to see on a pap smear, but you also do your high vaginal swab, which you can pick the Trichomonas vaginalis. Friable cervix, and they'll have a mucopurulent discharge. And microscopy, you'll be able to pick the microorganisms. Then for endometriosis, when the infection has gone to the endometrium, If it's an acute endometriosis, the uterus is enlarged and tender, and microscopically you see the neutrophils. If it's chronic endometritis, you'll see the plasma cells and a bit of fibrosis. If the infection goes to the tubes, the fallopian tubes, we get salpingitis, and the tubes get congested, edematous, and they have pus in them. Sometimes it could be connected to the ovaries. We call that a tubovarian mass when we feel it, the congestion and the pus-filled area. So it can be either a pus-filled tube or edematous tube. And this one, sometimes the problem is that they'll heal with adhesions, and that's how you get infertility because of blocking of the tubes. Okay. So clinical presentation, I already mentioned the kind of discharge they may have. They may have pruritus, itchiness, like a lot with candidiasis. They may have dysuria because of the infection moving up. Then low abdominal pain or pelvic pain, dyspareunia, that's painful sex. They may have a bit of postcoital dysfunction in PID, pelvic inflammatory disease. They may have irregularities in the menstrual, and then as a late presentation, they'll have infertility when the tubes are blocked. Okay, so complication again, pelvic inflammatory disease, tubal adhesions, which will cause infertility, have increased chances of ectopic pregnancy, chronic pelvic pain, the tubovarian abscesses, thyroidectomy, thyroid thylasemia, and then of course increased risk of getting HIV because of decreased immunity, and then multiple sexual partners, and then HPV. If you have the HPV infection, we'll see later it can lead to cancer of the cervix. Okay. For lab management, I think I'll skip this because you've done it in microbiology, but you can do your high vaginal swab, and then you do microscopy and culture and sensitivity. You can do PCR, you can do pap smears, you can do serology for HIV or syphilis, of course, imaging for abscess or PID. But the laparoscopy is usually the gold standard, especially when you want to see whether they have pelvic inflammatory disease. Management, treatment, you give the antibiotics or antifungal, depending on which disease the patient has. So if you're suspecting sexually transmitted disease, if you're in a lab where you can't analyze the microorganisms, you can do syndromic treatment. I see nowadays they use a lot of it's called VDM kit or VDT kit. We used to use that. Well, it has all these antibiotics catering for the different microorganisms that could be there. So syndromic treatment, of course, treat the partners, and then if there's pus, you drain the pus if there was an abscess. And then safe practices, health education, condom use, regular screening with the PAP and HPV. Yeah. I do want to say so much about infections because those are things that you have done. So I just picked a little because usually I would leave it out. Anything about infections that you have? Want to ask because I'm done. Anything on infections? This is just revision because you'd already covered in microbiology. Of course, we may ask you questions about infections because we're doing the pathology part. And pathology has 5 thematic units which I had introduced earlier. So microbiology is part of it as etiological agents. Okay. I only had, I think, 5 slides for that. So we can go to the vulva, the tumors, because we discussed about the infections. So we go to the vulva. The vulva is the outer part, the lips. Where you have the labia majora and then the labia minora. So there, you can have tumors, and you can have benign tumors and malignant tumors. So the commonest, of course, is the warts, the anogenital warts around the whole perineal region and also on the vulva. It's called the condylomas acuminata. So these warts, usually, maybe I show you the photo so that it becomes easy to see. So as you can see, the warts, those finger-like projections? It's a papilloma. It's a papilloma. This is in the penis. So you see the warts on the penis, warts on the penis, as you can see on the lower side. This is warts on the labia minora and majora, as you can see here, on both minora and This is on the anal opening, the first picture up there. And then this is also now on the perineal region, on the labia minora and majora. This is the wax. Okay. So the causative agent is human papilloma virus, the low risk subtypes, which is type 6 and type 11. And as I said, they can occur, there are multiple. If you see here, there are many, many, many. You can see they come as many, many, many. There are multiple. As I said, it's a papilloma. So they have the finger-like projections, okay, papillary, elevated from the skin. Microscopically, what we see is that we see the finger-like projections. And when you look at the cells, they have what we call the perinuclear cytoplasm vacuolization with nuclear angular pleomorphism, or what we call coilocytosis. We just say the nucleus is a typical. Plasma cells, again, will not over-harass you to see the cells. But this is important for you, is that you know that what causes the anogenital warts is your type, low risk type 6 and type 11 HPV. Okay. So we move to the high grade, you move from the benign, then you go to the high grade valvular intraepithelial neoplasm, which later then convert and become carcinoma in situ. Carcinoma in situ, then invasive carcinoma. So the picture I'm showing you here is now a malignant tumor of the vulva. You can see the way it is fungating. It's exophatic. It's coming outwards, exophatic. Okay, this is the whole tumor. There's a vulva, the whole tumor out like that. Okay. So of the genital tract tumors in women, and they're more common in women older than 60 years of age. The histological yeah. And when you take this on or neoplasm, then those are at risk of becoming carcinoma invasive. And the high grade V usually occurs in 40 to 60 years of age also. So there are a couple of these that you can also see on patients. So they'll go and they'll have valvectomy done. They remove radical valvectomy. So they remove the whole of this, including the normal tissue. Again, I don't want to discuss those in details. Yeah, part of the surgeon, but yes, that's what they bring for us. They removed the whole of that area. Tumor, you debulk, then you do your chemotherapy, radiotherapy, etc. Okay, so that's about the vulva. As I said, I'm going to just pick the most important parts. So again, for the vagina, we've discussed the infections that can be there. So we look at the intraepithelial lesion that can also occur, the same that you see in cervix or in the vulva. It's the same. You have an intraepithelial lesion, neoplasm, then it becomes invasive squamous cell carcinoma. Vaginal carcinoma is not as common. It's not. It's very uncommon and it occurs in women more than 60 years of age. The risk factors are the same as cancer of the cervix, which we are going to look at next. Yeah, and then there's a type of vaginal carcinoma, which is the clear cell type, because most of them are squamous cell carcinomas. So the clear cell adenocarcinoma occurs in women in their late teens to early 20s, and it's because the mothers had been given dithylstilbestrol during pregnancy. I don't think we do that much anymore nowadays, so we don't see much of these clear cell adenos. Yeah. So the commonest is squamous cell. But again, vaginal carcinoma is not common. No. Actually, the commonest is CA cervix, cancer of the cervix, which we will see. Yeah. So from there, I want us now to go to the uterus. So we've moved from the valve, we've moved from the infections, and infections I covered the whole of the tract. Then we look at the vulva and the vagina. So I stop here because we are now going to the cervix. Okay, I stop here. Okay, maybe I show you the anatomy, then we discuss the risk factors for cancer of the cervix. We review what we already know. This is your uterus. So as I said, we have finished the vagina and disorders. Then now we're discussing the uterus, this part. So here, as I discussed the uterus, this uterus will divide it into three. We have the cervix, we have parts just to know um, how they are and the diseases that are affected by them. Okay. So of importance for us in this anatomy, for the cervix, this is the part of the cervix. So I remind you, because I know you've done anatomy, that this part, you see this one which is in the vagina, this outer part that I'm touching with my cursor, this is the ectocervix or the portio vaginalis, the one that has entered. This one, histologically, is covered by squamous epithelium. Then the inner one, which is in the endometrial canal, okay, is covered by squamous cell, as by columnar epithelium. Okay, so here is usually the outer os up here. Then inside here is the internal os that feeds into the endometrial cavity. Okay, put a speculum on your lady who is lying down in the lithotomy position. This part, this one down here will appear like this circle. So this is the cervical os. Very important. Okay, this is just the normal anatomy that you know. So again, this is cervix, which is squamous cell carcinoma. Then squamous cell epithelium. Then the inner parts, endocervix, which is columnar epithelium. And then there's a transformation zone where you move from the squamous epithelium to the columnar epithelium here. Look at the photos on this side. This is squamous, and then this is the transformation zone, and then this is the glandular or columnar epithelium. Now you have to remember that at this transformation zone, or that transformation zone, is the zone where we get carcinoma of the cervix, the squamous cell type. That's why I wanted to introduce this part. It's very important. All this anatomy, this is a very important area. Okay, so we go to the cancer of the cervix now that we've done anatomy. I stop there to breathe in and out and ask, first, anything you know about cancer of the cervix. And I think the things I want to hear is about risk factors. I want to hear about screening methodologies. And I want to hear about diagnosis. Okay. And yeah, prevention. So start of the cancer of the cervix, epidemiology, risk factors, screening, diagnosis, presentation. Start typing, or you can unmute. You can unmute or start typing. So we're looking at any epidemiology, any risk factors, screening, diagnosis, prevention, anything on CA cervix. You only writing the risk factors. I want risk factors. I want uh, pre, clinical presentation, different. Okay, as someone has talked about prevention, screening methodologies, Okay, I want all that, not just one part. Okay, the 2 minutes are over. Let's see what people have said about CA cervix. Okay, pap smear is done as part of screening. True, that's from Marion. Etiology is HPV infection. True. Risk factors HPV. True. Risk factors multiple sexual partners. Men are diseases. See, HPV can cause penile cancer, anal cancer. The words that I just also vaccinate the boy child, or the men. Yeah, and there it is. Prevention is HPV vaccination. Then risk factors, early sexual activity is a risk factor. Very true, because you get exposed to the HPV. Pap smear routine screening for women over 21 years. Oh yeah, screening with a pap smear. In fact, I'll send you to do that homework of when you screen. Symptoms usually show when the cancer is advanced, but it can be prevented by regular screening for HPV. When it's not advanced, so you go for screening. Very true. It's curable when detected early. Yeah, that's true. At stage 1. Presents with abnormal bleeding like after menopause. Yes, that can happen. But before menopause, how does it present? January is the cancer awareness month. Yes, there's a lot going on right now about cervical cancer. Clinical presentation, abnormal vaginal bleeding, dyspareunia, very common. I don't know why you're not talking about postcoital bleeding. That's a commonest. HPV tests, checks for cancer causing HPV, and cells can also tell pap smear. Symptoms postcoital bleeding. Yeah, that's very important. That's one of the viral proteins changing. Great. You've said quite a lot, but you didn't tell me the epidemiology worldwide or in Kenya. But we have tried that, cancer of the cervix, which is what I'm going to send you home to read. The cancer screening. I'll send you, I'll tell you which document to go read. It's there in the government. Okay. So we look at cancer of the cervix, incidence. Incidence is when people have the disease of especially cervical interfere in 1 or 2, now becomes invasive carcinoma or actual cancer at about 45 years. Okay. So there's usually a period which you're going to see. Okay. Before now the occults or the invasive carcinoma occurs. So these invasive tumors are occasionally seen in women in their early 20s, carcinoma. So the ones in the early 20s, the other risk factors. Because like now I'm actually seeing, on my desk, I'm I'm seeing 20, or they have immunity which is low because like HIV cancer by I think 6 times. Yes. So there are those adenomas arise from the precursor CIN. Let's look at the cancer burden in our country. This is Global Can 2020. I couldn't get friends, it's almost the same in the 2022 one. If you look here, the incidence of the disease, breast cancer is really higher than cervical cancer. The breast now, mortality, cervical cancer is killing more than the breast. Okay, yeah, just a small change, but yes, it is there, killing more. Okay, and this is what I see on my desk, unfortunately. Okay, so that's the Kenyan burden. This is burden in our country. Okay, yeah. So there's a lot of CS cervix and it's killing. Okay. So quick fact is like all women are at risk of cervical cancer. It is most common among women aged between 35 and 49. HIV and AIDS, now that increases, it makes even the cancer more aggressive. So cervical cancer with HIV and AIDS occurs at an earlier age. Okay. Therefore, even screening, the way we screen for patients who have HIV for cervical cancer is slightly different from how we'll screen for the ones who are HIV negative because of this. And the disease you get it is more aggressive for you to get the cancer of the cervix. Yeah. So that's an important factor. Okay. So risk factors, you've mentioned all of them, so I'll rush through. Early sexual intercourse, like before 18 years, early course, intercourse, HPV infection. Okay. So, and then having multiple sexual partners, if you have multiple, you don't know which one of the many multiples has HPV and will give you the HPV. So when you have multiple, you're just increasing your chances of getting the infection. And then a male partner with multiple previous sexual partners, you never know whether he had picked from those various other well. And then women with STIs and STDs, including your HIV infection, etc., the immunity, and also the fact that increasing the chance of HPV is higher when you have these other sexually transmitted infections. Patients with immunosuppression, again, your immunity is low, so even though you get the infection with our immunity in a few slides, okay? Then we have poor economic status and poor personal hygiene. I know you'll ask how this occurs, but people with low economic status will not have, health education. They'll not afford to go even for screening, or HIV. Sometimes they may be involved with high risk things, or their immunity is low because of even malnutrition, etc. So that increases their chances. Smoking also. Smoking, as I said, you say smoking every mothers with many births, or what we call high parity, multi-parity. Okay, multi-parity. And you have many, and maybe some people during pregnancy, and then also during delivery, you've had many children, some chances of your HPV mucosal damage and HPV penetrating in. Okay, yeah. So those are some of the head, and there are many more. You've even written more there. Just go and add more and more high risk factors. Okay, yeah. Then we go to the pathogenesis. It was mentioned briefly in the group by Kakinya, who mentioned about the viruses, oncoproteins from the virus. It's from HPV infection. But let's look at which part is affected. So important is that transformation zone, the one I showed you, where you are moving from squamous epithelium to columnar epithelium. That junction where they meet. We call cervical cancer occurs. Now, since the zone is located within the cervical os, it's unable to view it routine pelvic exam. Usually we have to put a speculum, then we put our brushes so that we are able to go there. Eh? It's not easy to just see it. You saw how it's located. Eh? That's what we mean. It's located here. Okay. Here. Here. This is the junction I'm talking about. So it's inside here. Okay. Yeah. So you will not just see it, in the routine exam. Okay. So that's what we mean by that. But now, expression of these abnormalities that you will be seeing in the cells. Okay. So usually they say even HPV and cigarette smoking can HPV does it because it's been shown that 99% of squamous cell carcinoma is due to HPV. Okay. So we're going to look at HPV in detail. Okay. So which are these HPV subtypes? They're like 1,000. There are very many. Okay. And they're the ones that are causing the genital warts, the cervical dysplasia, and the cancer, cervical cancer. Okay. Of course, HPV can cause oral cancer, penile cancer, anorectal cancer, vulva, vagina. But now we're dealing with at the cervical level. Okay. So the low risk subtypes, which are type 6 and type 11, will cause the warts, as we've seen before. Then the high risk, which are very many, of importance is your 16, 18, 31, 35, and 45, I think. Yeah. Those are very important. These are high risk. They may lead to dysplasia and cancer. Okay. And how does it do that? Prevalence or infection is more at the 20-year-olds. This is the place they're excited. That age group, Mukingia campus, there's freedom, there's excitement, you want to explore without any, limitations, etc. So there's a high sexual debut at that time. And so people are just sleeping around all over, so they'll get the HPV. Okay, so the prevalence is high at that level. Then the subsequent, this decrease in this prevalence because of patients getting people getting immunity, and then they move from polygamous. Now they start settling down into having one regular partner, etc. So monogamous relationships. Okay. Now we see that most HPV infections are transient, and they'll be, and I'll show you that trend in a few minutes. On average, we see that 50% of HPV infections are cleared within 8 months. Yeah, 50%. You get the infection. That's why the debut was prevalence was 20 years. Then after that, if you test those people, the HPV has been cleared by immunity. And especially if you now move into the monogamous relationships. Yeah, and then 90% of infections are cleared within 2 years. Okay. So what matters is the duration of the infection is related to the HPV type. Okay. So on average, infections with high risk, the type 16, type 18, all those last longer than those ones which are low risk, like your type 6 and 11. So those ones can take 8 months. And the high risk ones will take a longer period than the low risk ones, a shorter period to be cleared from the body. Now, of importance is my last sentence, that if the immunity does not clear that, so you have persistent infection, it will now increase your chances of getting cancer of the cervix. Okay? Yeah. But you can see there is that clearance that usually would happen. Okay. So the carcinogenesis, so we have had the infection. How does it get in? So through sexual transmission. Then what happens is that the HPV now infects the immature cells in the transformation zone or the squamous columnar junction. Then they start replicating in the mature cells. Okay. Remember, it's a virus. So a virus can't do it on its own. So it has to incorporate in the host genome. So it has to get into a host genome. Okay. So far, it's able to replicate. So it has infected the immature to a host genome so it is able to replicate. Okay? Yeah. So that now the DNA synthesis is induced in our host cells. So what it does, it gets into the cycle. Okay? It reactivates the mitotic cycle. What it uses, it's viral proteins, E6 and E7, okay, and a bit of E3. P53 tumor suppressor gene. So the oncogene E6. This we've already done, but I'll repeat. Then of course, you know the role of P53 tumor suppressor gene in the cell cycle is the one that causes, the abnormal or the infected tumor cells that have tumor, they have DNA damage, to be removed from the cycle and they're killed, apoptosis. They're the ones that lead to programming here. The viral protein from the HPV virus usually comes and degrades or stops the work of P53. So the cells that are already damaged or infected by HPV will now not be removed from the cell cycle because there's nothing to remove them from the cell cycle. The P53 has been degraded. It has been degraded. Now, for the E7, it's going to complex with the retinoblastoma gene, the RB gene. Okay, remember what RB gene does. RB gene is the one which helps us to get into the S phase, okay, of the cell cycle. It usually binds to E2F transcription factor. Then it gets you into the cell cycle, okay? So now, when you have the E7 getting into the RB, so the cells just continue in the whole cell cycle now will continue making cells. So one cell becomes two cells, etc. There's no killing because the P53 tumor suppressor gene is not there. So these are cells which are mutated. They have been infected by HPV. They just continue the cycle and more have uncontrolled proliferation because there's no limitation that usually happens at the RB gene for the cells getting into the cycle. So those are the two main problems that we get. So you have continuous proliferation and there's no balancing of killing those abnormal cells, okay? So those two viral oncogenes cooperate to promote DNA synthesis, okay, and interrupt the apoptosis. So you end up having increased lifespan of cells and increased cell proliferation. And that's how the tumor, one abnormal cell becomes two daughter cells become 4, become 8, 8, 16, 16, 32, etc. That's what happens, the clonal expansion. And the reason is because of those two viral oncogenes that they had incorporated. And that's what we are saying here. So HPV infection, as you can see, there are many subtypes. So you have your normal cell here, you have the infection here. Of course, as I said, it can get cleared in 93% of cases, so you go back to a normal cell. Then there are those that may progress to this is low squamous cell intraepithelial lesion, or CIN1. I'll show you that in a few, but we covered them in general pathology. So this CIN1 can progress to CIN2 and 3, but some may regress and go back and become normal. But the ones, if you have persistent infection and you have other things like STIs, immunosuppression, smoking, etc., then you're unable to clear. Your immunity is unable to clear. So there's persistent infection, which becomes carcinoma. So the latency period can be up to even 15 years. Okay. Yeah. So it can take time. Genes I've talked about, the E6, which binds to P53 and blocks programmed cell death. Then your E7, which releases the E2 transcription factor from the retinoblastoma gene, which makes the cells to get into the cell cycle. Okay, that's the main problem. So this is just a repetition of what I have said, the different types. But this one now shows you, see this, I was just showing you one cell with infection and persistence. Now this one I show you the squamous epithelium over here. So as we said, they come and infect the inside. As you can see here, they're replicating like this. HPV infected cells. So when you do a pap smear, we're able to see these HPV infected cells. You see coilocytes. And now when it has gone to invasive, we see now abnormal cells, neoplastic cells. see here. So just how those things go. And for testing, you do HPV DNA probe, as you can see here. So I have mentioned CIN here, or even here. And so I'm going to describe what CIN is. But are we okay till there? Okay, I don't see any queries. So we can continue. So because I've talked about CIN and the low seal and high seal, I want to explain what they are. Okay. So for the CIN, what it means, it just means they stop. Okay. So we are looking at the squamous cells. How do they look? So then we classify them. So we have what we call mild dysplasia, moderate dysplasia, and severe dysplasia with an intact basement membrane. Now, there's what we see on histology, and there's what we see on a pap smear, which is cytology. Low seal, this low squamous intraepithelial lesion. If it's CIN2 or CIN3, as I've written down here, we call it high-grade squamous intraepithelial. This we see on a pap smear. When it's on tissue, it's CIN. Okay? Okay? That's how we describe them. And I show you on a photo because it becomes easier. Okay? So here is our normal squamous epithelium of the ectocervix. So we have a basement membrane down here. Now we say when you get infected by HPV, it starts from the lower side, the immature cells, then it replicates in the mature cells. Okay, so this is what we are going to be seeing here. Okay, so when you have mild dysplasia, it affects just the lower third with an intact basement membrane. I want you to remember this lower part. This well-lined cells, that's a basement membrane. Okay, so it's only affected the lower third, which we call CIN1 epithelial lesion, which we see in a pap smear. When it has affected two-thirds, we call it moderate dysplasia or CIN2. When it has affected the whole full length, CIN3 or severe dysplasia. Of note is that the cervical, the basement membrane is intact, which is also the CIS, carcinoma in situ, okay? That the basement membrane is intact. Now, when the best we say we have invasive carcinoma. Invasive carcinoma. This is what we are saying in those 45-year-olds. Okay. But you can get it earlier if you have immunosuppression. Okay. So this is what I was saying. This diagram is showing us with the infection. You see the replication of the virus, etc. Then here it's become tumor. Okay. That's what I said. Two-thirds and then full thickness, but with an intact basement membrane, okay, which I'm showing here. Here, I just want to show the cytology or what we see on pap smears. So this is the cervix. Remember the one I showed you, this is the internal os. So this is normal cervix. And this is what we see on the pap smear. So we see the different cells. This is okay. They're exfoliated. They fall off onto the pap brush, cyto brush for pap smear. And this is how they look. That's normal. Now here is when they're infected with HPV, okay? So this is how it will look like, the cervix itself. And this is the HPV infection. These are called coelocytes. So you see them on the squamous cells, okay? So you can see this one has a double nucleus and there's a halo. There's clearing around the nucleus, like a vacuole. It's clearing. That's a nuclear halo that I was talking about. And the nucleus is atypical. So these are coelocytes. So this is early infection. We call CIN1 or low seal. Okay? And as we said, it can be cleared and you go back to normal. Okay, now here it's the precancerous stage. Now this is CIN3, CIN2, CIN3. Okay, this is how we see it. Okay, so you see the cells have now changed, dysplasia, different shapes, different sizes with hypochromasia, a dark nucleus. Here we are, you're seeing that now here. Different shapes, different sizes with a dark nucleus. This is dysplasia. Dysplasia. a CIN2, CIN3, or a high seal. If I see this on my pap smear, I call it a high seal. Then the last part, as you can see on this cervix, this explains to you why they have postcoital bleeding or intermenstrual bleeding, because you can see this mass, the way it looks, it even just looks like blood. So if you have sexual intercourse and, this blood is, just a bit of shaking and everything, it just pours out. So that's why they say postcoital after sex, after intercourse, I see you're somewhere here. Okay. And this is what I see on a pap smear. You can see like the tadpole cells. There's a lot of tumor diathesis. Okay. A dirty background. Okay. Yeah. So we call it invasive carcinoma. So that's what we see on a pap smear. So a pap smear can tell us, okay, some of these. Okay. So the histological types, the commonest is squamous cell carcinoma, as I said earlier. Then you also have adenocarcinoma, because we're having endocervical cells which are columnar. So endocervical cells which are columnar lead to an adenocarcinoma. So we can also have an adenocarcinoma. Adenocarcinoma is not as common as squamous cell, counts for about 5 to 20%. Related more to, I think, HPV 18. But squamous cell is both 18, 16, I think 31, 35, etc. Okay. Then there are others that you can have, like your clear cell or neuroendocrine. I'm dealing with a neuroendocrine right now. I'm just about to do the immunos for cervical carcinoma to see. As I said, these things are there. We're just seeing them all the time. Like I just did the pap smears for where we rotating Mama Lucy. So I'm the one who was on call the other week. So I had like 20 something pap smears. And of course, some of those pap smears are not normal. So it's a good way of screening so that we know. Type is squamous cell carcinoma, as I said earlier. Okay. Yeah. So clinical presentation, people said it very well. Early disease asymptomatic, because you can actually see here, and that's why you do testing. And somebody mentioned in the group, okay, early disease here, which is classic, and I've showed you why you would bleed. Then postmenopausal bleeding, if they're already postmenopausal, they may bleed, and yet the menses were over. Then intermenstrual in between, they may bleed. Then foul smelling discharge. You can imagine this. When you have this, okay, you can have discharge, foul smelling discharge. Okay. Then pelvic pain when it has, moved, spread. Okay. Dyspareunia also usually happens. Okay. Painful sign. Then weight loss in advanced disease. Tumor checks here. So I show you photos. So in physical exam, cervix may appear normal on general infection, or they can have an ulcer that bleeds. I showed you those examples here. Okay, the different ways that the cervix can look. Okay. Then other times, and I have seen this, sometimes people stay at home. By the time they are coming, you put your speculum and you're seeing something fungating like this. Or cauliflower, it comes out like that. Yeah. We see that a lot. Okay, so that's how they'll present. That's how we'll see. Okay, when you put your speculum, this is what you see. Of course, this is someone who has been removed the uterus now, and we're able to see this. But we see this inside the person. We tell them, sleep, we want to do a pap or something, then you find the mass. Okay. Yeah. Advanced diseases, you may feel a mass in the pelvic. The morphology, what we see, okay, then the ulceration. This is how they sit. This is lithotomy position. Okay. This one, it has spread. You can see the tumor. You can see this is a uterus. You can see the uterus nicely. This is into half. Okay. Yeah. See, there's a urinary bladder at the back here. This is the colon. Then you come to the rectum here. Rectum, then anal opening. So here is our uterus. You can see the tumor. This is the tumor. All this whitish, creamish thing you're seeing here, it has spread to the gut. As you can see, it's coming in and penetrating into the rectum. okay, coming all the way to the anal opening. The whole vagina is affected. You can see the whole of this is vagina. Because this is where they're all supposed to be, but there's a mass going all the way. This is supposed to be the vagina. It has the disease, the whole of the vagina, both and walls on this side. This is going to the bladder. You can see the bladder has also urinary bladder been affected. This advanced disease, which is stage 4. Figo, I think something like that. Figo. So this is how they stage it. Okay. Stage 1 is confined to the cervix, as you can, but doesn't go to the pelvic wall. Okay, the pelvic wall would be here. Doesn't go there. So there's something we say upper vagina, lower 2/3. You'll hear that with our gynaes. Okay, then stage 3, it has now gone to the pelvic wall. Okay, as you can see. Okay, then stage 4, it has gone to the bladder, urinary bladder, and in the rectum. Go stage to show you more things. Okay, so screening. It was mentioned in the group about screening and diagnosis. Okay, so we said screening, we use a pap smear, we do HPV DNA, and then there's low income places. We can use VA and things that so you do biopsy. Different ways of doing biopsy. You do a colposcopy, then you pick the abnormal area and cut. And this can either be a cone biopsy or a punch biopsy, which you bring. Okay, yeah, I'll show you those ones. I have a photo for remember. I'll see, but let's discuss pap smear. Okay, so you have pap smear, you have HPV. Okay, so for HPV, there are different subtypes that you saw. So we are able to do like now. I remember in the some of the projects that we are doing. So we took about 1,500, or I think 500 or more kits for HPV testing to the county hospitals. Yeah, so we took to county level 5, and then the ones level 4, level 3, those ones, the ones that have the gene expert machine. The gene expert machine is a PCR machine which checks for TB, but you can also test for other things. So we have taught the people in those county hospitals and taught them how to do HPV testing. So they're actually able to do that. So you can actually run on that module if you don't have the big machines. It's the same way we used to do COVID, SARS-CoV-2. We're using the same machine. So it's the same thing because it's a PCR. So we're able to test. I just needed to say that. And I think we have more kits from the national that we're going to send next month. I think we're supposed to be next week, but one. I think I'll go distribute some others to some other counties on the other side in the western part. These ones we took in November. We took some to, we're covering that county is called Nyandarua County. October, we took to Machakos County and its environs, and Kitui. But we also, I think it's called Kitui, not Kitui, Machakos. Yeah, Machakos is where we were. I was trying to remember the other guys who had come in, whom we were training. Yeah. So we do like that. The different researches that are going on that help with testing. Okay. And even at the national level, we have very big machines for HPV testing, which can also be done. Okay. Yeah. Okay. So we have discussed HPV testing. So VI means visual inspection with acetic acid. You like vinegar? That's acetic acid. Eh? So what we usually do, we put the speculum, and then now you put acetic acid. Eh? You see, this is the cervix, this is the os. Okay, this is the external os here. Then we've painted it with acetic acid like that. Then what you see are white plaques, these whitish things, these are the abnormal cells. Because they have high levels of proteins. So they'll take in the acetic acid, so they'll become aceto white. That's why you're seeing them whitish like this. So these are the lesions that we pick that there is abnormalities going on. This is how we see on the screening. In fact, like now, what we are doing, we do something called screen and treat. So what happens? They go, they screen like this, they see these parts, then they treat. So you do cryotherapy. I'll show you the last slides what we are doing, so that we treat these ones. But when it's a fungating mass, now we'll do colposcopies, con biopsies that now they bring to the pathologist. But at the level when we just screen and we do something called screen and treat. So we've been doing all this many places. I participated the one for Machakos, after Nyandarua, we are going to Western, like that, where we do those things like that. Treat and screen and treat. So you see this, and then you treat. Okay, this is using the acetic acid. Then you can also use more just of the other one. Yeah, but for the this is acetohyte, so as you can see, this is the one I've just finished talking about. This is a positive case. Even this was a positive case. Okay, so when you're using glucose iodine, usually the iodine, like the one you use for gargling and all that, usually what will happen, the precancerous or the cancerous cells usually have this color, yellowish. Okay, so this is a positive one. Okay, yeah, but I can tell you we are doing more of this. Okay, yeah. I picked it from a certain study that was being done in Zim or Mozambique, one of those countries. Yeah. Okay. So then we go to the pap smear. Okay, so pap smear again is just putting the speculum. The patient is lying down like this. You come and take the sample from the cervical os. We want to aim to get into the transformation zone. So that's why we push the brush so that it comes to the transformation zone there. Then after you take the sample, you put on a slide like this and you fix it immediately with alcohol, and then you stain with the Papa Nikolai stain. This is from that guy called Papa Nikolai. That's how it was discovered. Yeah. So that's the pap smear and how we do it. Then the colposcopy, so that you can be able to do biopsy. Okay. So it will help us see the areas of suspicion. Okay. When you paint now with the acetoacetate. If they are abnormal, then you take a biopsy. Okay. So this is the scope, colposcope. So here is a speculum like this. Then wanamulika ndani. Okay. Then you'll see those abnormal areas. Then you'll take a knife and cut. Okay. Then bring that biopsy for histology. This is how they do a cone biopsy. You can see it's going around. So this is the abnormal cells were around this area. So they will do a cone biopsy like that. It comes out as a cone. You see here, it comes out as a cone. And that's what they bring to the pathologist. And this is how we report and tell them what is going on. That's a cone biopsy. I didn't do a punch. I didn't show you a punch. It must be somewhere. You can just Google punch biopsy. Yeah? I think I wrote for you here. Punch biopsy. Yeah. Like the one you do on skin. It's the same thing. Okay. So I've talked about diagnosis and screening. Let me go back to be number one. It's just that not everyone can afford HPV DNA. And perhaps areas you do VIVly. Okay. Diagnosis, as I said, is biopsy. Either biopsy can be a cone biopsy, a punch biopsy, depends on what you see on colposcopy, and then do the biopsy. Okay. Just explaining those different methods. So general management will depend again on the stage. If you pick them when it's just CIN1, the ones you've seen, it's just a third of the epithelium that is affected, or 2/3, etc. There are different methods of treating that. And you want to preserve, maybe it's a lady who's not had children, they're still in the reproductive stage. So you'll do this. Pre-invasive disease, you do this. You can do cryotherapy. You can do LEEP. Okay, LEEP is loop electrosurgical excision procedure, or you can do LETS. This is just like loop, it's just that you're using a large a large loop to do this electrosurgical excision. A large loop. Actually, LETS stand for large loop electrosurgical the excision follow-up. We keep on doing pap smears for these patients. Let me describe cryo on the loop. This is the loop, okay? So you can see this thing here, okay? It has a loop, a wire. It's a loop wire. Okay, it has a wire attached to it like this. So when they've done acetoacetate, like this one here, you come with that loop. Then they'll use the loop to cut off this area. It's an electric one. It just removes these abnormal cells. That's what I'm showing here. Here. So it removes this like the abnormal cell. So it's going to loop it out like that, and you'll see the area with the abnormal cell is out like this. That's loop. Okay. So the wire puts it out like that. This wire like this, pulls like this. Okay. So this is loop. You're seeing the way it's cutting through. Cryo, they use like liquid nitrogen. Then they'll put in like that. Of course, they first give thing which has like liquid nitrogen. It's then it freezes. It freezes the cells there, the abnormal cells. It will freeze them for like 5 minutes. Then it thaws them. Then it freezes again. No, that's how it kills. That's a methodology for killing or eliminating those abnormal cells by freezing cryo. Okay, so it freezes. Usually does freezing for like 5 minutes. Then it thaws them again. Thawing is like melting a bit. Then it freezes again. Then it comes out like a ball. Like an ice ball. That's how they come out. Again, these things are. It's even you see them being done, and there are many campaigns that go on and they do that. So that's how you do cryo and leap. Then con biopsy, I showed you this one. Yeah, so that's what you do for the pre-invasive disease. Then early stage invasive disease. So usually what happens, if I see high seal, I ask my in situ, you never know whether there's a place where it's invasive. So you'd rather do a hysterectomy and radiotherapy. So then locally advanced disease, you can add now chemoradiotherapy. And very advanced disease, like what we saw going to the rectum, to the urinary bladder, you just do palliative. Okay, pain control, supportive treatment if there's anemia, if there's a fistula, communicating between the vagina to the bladder, etc. You try to manage all that, and psychosocial. Yeah, that's the end. These are the photos I was showing. Vaccine, as we said, prevention. There are different vaccines that you can use. Okay, so there's a bivalent, the ones we have here. We have the cervix, and we have and we have Gardasil and type 18. These are high risk viruses. Then Gardasil is a quadrivalent. It will cover the low risk 6 and 11, and then the high risk 16 and 18. There's the non-valent. I don't know if it's here yet. I don't know, but it can cover 9 subtypes. Again, this vaccination is most effective before people get into the sexual debut. That's why we are vaccinating our 9-year-old girls before they get there and get into that lactic. It's prevention. It's like when you do those babies when they're born, you give BCG, all those. It's the same thing here. That's what we're giving our 9-year-olds. Okay, prophylaxis. Okay, I tell older people, you get usually advice. Let's test. If you're negative, now we do the vaccine, and the tests are not expensive. In fact, right now I'm trying to follow up with those colleagues of mine that we're doing those projects, because at the national level, I know we have a very big module, a very big machine. I think they should be charging 1,000 or 2,000 only for all those modules. You just test, and then we can give the vaccine. Okay, yeah, and it prevents over 90% of HPV-related cervical cancers. Okay, yeah, so like the one for COVID really brought for us issues, but yes, so this one has been shown to prevent. Okay. Questions? as we breathe in, you'll have to look at the yeah, you'll have to check on the because it's there. It's there. There's how we test. I couldn't locate it in my work. You can read the book. It's usually there, that book. Hello, are you people there? You even become less. Faith, am I talking to myself?
No, we are listening.
Oh, Julius, I even thought you are not there. Eh? My Timothy's,
No,
are you there?
I'm in. I'm in.
Okay, you do know, you people are so quiet. I thought you would ask questions. Mmechoka sana.
Concentrating. We are concentrating.
Oh,
Focus.
okay. Oh, you're focusing, eh? Now, I'll
Yes,
send you
we
to go
listen.
and read that. Yes, Timothy, you're there. Okay. I'll send you to check, eh? It's there. You if you go to early detection, and I was trying to remember how to usually call it. There are those government early cancer detection. That book, early cancer detection. Yeah, cervical cancer detection. There's a book we've written. Okay, I didn't write that one. I wrote a different one. Cervical cancer detection. There's a book, government, that we use. There's a book, Kenya. You just write Kenya. It will send you with that book. Guidelines, eh? Kenya, there's a guidelines, eh? There's a guideline. I'm trying to remember how we usually say it, that book. Eh? I can't see it. Government of Kenya. Yes. It's National Cancer Screening and Early Diagnosis Guidelines. Okay? It will be there, especially for cervical cancer. They will show you all those, where we say the population, women younger than 21 years, you don't screen. The ones between 21 and 29, they will use just pap smear. Then the ones for using HPV. It will tell you all that. And women above 65, if the pap smear is negative, then, there's a time we stop. You can't be sending them every time, every pap smear, and then if you've done HPV and cytology, then cytology. You wait for 5 years. If it's HIV, they don't wait for 5 years. Okay? HIV, you do 3 years. It's shorter. Yeah. Just read that book. It's there. It's there. I forgot to pick up in my teaching for today. I was trying to look for it and I can't find it. Yeah. Okay. So any questions before we go to the endometrium? Remember, we have just done the cervix. We were just down here. Oh, we can even use this photo. We were here on the cervix, and then we finished. So we started with the vulva, then we went to the vagina. This is vagina, like this. Then we were on the cervix here. Now we're going to go to the endometrial cavity here. Then we go. So which disorders do you know of the endometrium? Which diseases do you know of the endometrium?
Endometriosis.
Good. Keep talking. Endometriosis. Continue. That's just one. Keep talking. Which diseases? You can't say just one. No one is even typing.
Endometritis.
Endometritis, which I had just mentioned a few minutes ago. Yes, I said endometritis. Metritis is different from metriosis. And now even you people, honestly, Timothy, you can't even say cancer, that endometrium can get cancer.
Adenomyosis.
Hey, thank you. Yes, adenomyosis. Good. You see, you people know. You know now it's at the end of the day. If you don't talk, I'll feel like I'm just talking to myself. I'll feel so wasted and so harassed, and I'll not sleep well. So I'll feel like I've not achieved, and it's an important topic. Yes, polyps. You can get endometrial polyps. I actually didn't say you can get endocervical polyps too, eh? But endometrial polyps are there. Actually, I reported one today, an endometrial polyp in I can't remember the age of the patient. I did endometrial polyp, yes. They're there. Okay. So let's look at this. So the commonest presentation of these women will be abnormal bleeding, isn't it? Yeah. Okay. So let's look at this. So there are those we call functional endometrial disorders. And these are just abnormalities in the menstrual cycle, okay? Resulting from abnormal uterine bleeding, okay? Now, when people have abnormal uterine bleeding, you'll see as writing AUB, abnormal uterine bleeding. It could be either because of a structural problem. You know, when you look at morphology, you actually see there's a problem with this organ called endometrium, okay? Or this organ called uterus. That's organic or structural pathology. But the biggest group of abnormal uterine bleeding is dysfunctional. Okay. Now, what do we mean by dysfunctional? Okay. Remember, it's like in the menstrual cycle, it's a cycle. There's what is coming from your pituitary to the gonads, and then to the endometrium, and then you bleed. So it's a cycle like that's the okay. So we call it dysfunctional. So it's a clinical term for uterine bleeding, not caused by any structural abnormality. Okay, it could be a hormonal thing, and you can't pick. It's just hormonal, too much, etc. But the other one, which is structural, we can actually pick. And my next slide just gives you different causes that can lead to the abnormal uterine bleeding, and I show you here. Puberty, you may have abnormal uterine bleeding. Remember, this pre-puberty, so they have not started the menstrual cycle, but they are bleeding. So especially patients who have precocious puberty, early puberty, before the 9-year-olds, before 9 years of age, when puberty starts, so they are bleeding. Okay, I'm sure you did this in clinical chemistry. There's a whole topic that we cover on infertility and precocious puberty, and what else do we cover there? PCOS, that's under precocious. Those are the topics we cover. In infertility, we always talk about precocious puberty. In clinical chemistry, which you told me you did, I think in term 1. So you'll remember. Okay? So precocious puberty. And many times precocious puberty is because of the axis, axis. Now it's ovarian axis. Okay? Then we have adolescents. Okay? For them, it's because they have a list. Okay? Then reproductive age, there are quite a number, very many, depending at what level of this age, reproductive age. So one of them is if there's a pregnancy. They may bleed because they're having an abortion. They may bleed because they're having a gestational trophoblastic disease like your hydatidiform mole. They may bleed because they have an ectopic pregnancy, a pregnancy which is not in the uterus, it is in the tubes, which we call leiomyomas. Or because they have adenomyoma, which we're going to talk about in a few minutes. Or they have polyps, or they have endometrial hyperplasia, which we'll talk about in a few minutes, or they have endometrial carcinoma, okay? Or it's just an ovulatory cycles, you're not releasing it. Then perimenopausal, around that region of menopause and irregular shedding in atrophic endometrium. Then organic lesions can be either cancer or hyperplasia or the polyps. Okay. Then post atrophy cells or lesions, and the commonest is carcinoma. Okay, endometrial carcinoma. which is what we are going to see in a few minutes. Okay? So you can see these many things here. Some you've covered, some you've not. But now, because we are just discussing disorders of the endometrium, I needed to put all this here because we'll talk about some of them. Okay? That many times endometrium, what we see is bleeding. But what are the things that can cause bleeding? These are the things that can cause bleeding with the endometrial problems. Okay? This is a thing that I really needed to present. Okay? Because it helps you with differentials. Okay? Yeah. So let's look at the endometrium being infected or inflamed, and it's called endometritis. It's not common. The acute one is not common, okay? And mainly it will come from infection, either like after an abortion or even after deliveries when people have retained POCs. POC stands for product of conception. Product of conception. Could be the chorionic villi that we see, because when you conceive, the chorionic villi starts being formed, so they can form the amniotic fluid and, all those things, the placenta, all that. Like if you say patient had an abortion, so it's incomplete abortion, so they're bleeding. So you need to go in and do MVA, manual vacuum aspiration. You remove all the products that are left there, the chorionic villi, the small pieces that you find there, you have to remove all of them. You have to clean them. That's why we always, if you go to the gynae ward, if there's any incomplete abortion, you'll find MOs on rota duty to just clear, to do MVAs. Because if you retain that, they can get endometritis or they can bleed even to death. Okay, they can even get into DIC. So products of conception are the biggest culprits for getting endometritis. Okay. Then I'll tell you a story of the other day. I had a young patient. This thing has I look at this, I'm just seeing, looks like this inflamed, but it doesn't make sense. So I look, I'm like, okay, I'll wake up and look at this, sleep on this thing, and then wake up in the morning and look at it again. So when I woke up, of course, I discovered there are just hormonal problems that the patient was having. When I looked at it, I remembered of the other diagnosis that sometimes we leave. It's called a disordered proliferation of the endometrium because of the hormones. And I remember discussing with my colleague, like, you're the one who has always reported this. How are you not reporting now? So he even laughed. He's like, you must have been very tired, Yeah, so anyway, but I haven't seen much of endometritis. Although there's the one I told you that today, I think it's TB, but I have not released it. I need to go back to the tissues again and also have my colleague look at it. I think it's TB. But yes, so the commonest other microorganisms, if it's not because of delivery or abortion, is that you can have STIs like your gonorrhea, trichomonas, chlamydia, or mycoplasma. Again, inflammation, because it's acute, you see neutrophils. You can say there are many neutrophils here. Others are even inside the glands, like this. They're inside the glands. This is marked inflammation. So management, I know Julius will always ask me, you do a curating, you remove all those POCs, you remove everything, and you give antibiotics to treat that. Okay. If it's STIs, of course, you give the syndromic treatment we talked about earlier. Okay. So for chronic, again, in chronic, you'll now see chronic cells, but the causes of chronic endometritis is chronic PID, pelvic inflammatory disease, can be at postpartum or post-abortion patients who have retained POCs, they've stayed longer, or a woman with IUCD, intrauterine contraceptive device like the coil, okay, and then women with TB, okay, either from military spread or from drainage from the tubes, okay, salpingitis or tubovarian abscess. So these ones can lead to chronic endometritis. Acute, you can see there are many neutrophils. These two small dots that you're seeing, like here, where inside this gland. Okay. Quiet, your hand is up. Quiet. Or is it a mistake? Okay. Like here, this is neutrophils. You're seeing very many. Now, in chronic, you see plasma cells and lymphocytes. You can see the many plasma cells here. Okay, you see these ones? Like this. All this. Now, this, we call it chronic. Okay, and many times this patient will have abnormal bleeding, they may have pain and some foul smelling discharge, and again it may, so that's infection. Again, not as common for endometrial, but not as common, because many times nowadays we get someone with retained POCs or incomplete abortion, we clear it. That's our role. Okay, yeah. So we move to what people mentioned commonly, which is the endometriosis and adenomyosis. So I need someone to, and please don't Google. Don't Google, you just write what you think is endometriosis and what is adenomyosis. Please don't Google, just define without Google what you have on top of your head so that the class can be interesting. Endometriosis, yes, Timothy?
Outside. Development of the endometrium outside the uterine wall.
Correct. At first you had said uterine tissue. That's why I was correcting you. It's endometrial tissue outside the uterus. Okay, endometrial tissue outside the uterus. Correct. That's
Adenomyosis.
Mm-hmm.
Adenomyosis is when now the endometrial tissue grows into the uterine muscle.
The myometrium. Uterine muscle is called myometrium. Very correct. That is true. That is correct. That is correct. Okay. So those are the ones we'll discuss now in the next maybe 5 or 4 slides. Okay. Meiosis. So we discuss it in details. Okay. Yeah. So endometriosis, as we said, is the presence of endometrial tissue outside of the uterus. Okay. So we are finding it outside the endometrium and outside the myometrium. It is somewhere else. You'll find it in the lungs, you'll find it in the umbilicus, you'll find it in the appendix. That is what we mean. In the colon, in the blood. Okay. It's common in the 3rd and 4th decade. Okay. Yes. And occurs in about 10% of women. Okay. So for clinical features, it has this triad. They silently call it a triad. You see, they have put it in italics just to show the triad. That what the patients present with in 30 to 40% is infertility. And from your clinical chemistry, you know the definition of infertility. Who can define for me infertility? And please don't Google. Who can define for me infertility? Please don't Google. Please don't Google, just define. I'm waiting. Oh, people are typing.
Inability to inability to conceive even after regular and protected intercourse.
Okay. Another person. I'm trying to see. Oh, there's nothing. Oh, see, just topic of typing. Okay. Inability. Let's pick inability to conceive for a period of trying. I will give you. I didn't want to be so mean and say I want to give you marks and not to give you full marks. Maybe I was hoping that someone else has said not being able to conceive to her a live birth. No way. It's not a thing about live birth. Okay. So infertility is inability to conceive after unprotected. Unprotected. Very important to say. sexual intercourse for a period of 1 year. You have to say the period. And we even check, it has to be regular. You can't say, I'm not well, but I had sex in January, then now the next time you had was April. It has to be regular. The next time I had now Jan, then it was quarterly. You do Jan, then you wait, another quarter is in April, then the other quarter is in August, and the other one is in October. Then you say, I'm not. So it is not correct. You cannot call that infertility. And then protection. You see, if you're using protection, then you can't. So infertility is a very important thing with this as a triad. So definition.
Excuse me.
Yes.
Does that cover men also? Because also men suffer from infertility.
But of course, I'm talking about infertility for both. That's a definition for both. It's not one person. Hey, you guys, in clinical chemistry, you didn't cover infertility. A topic. Faith. Okay, Julius, now that you're the one who has answered for me the question, you didn't cover infertility in clinical chemistry?
No, we didn't look at it as a topic that way.
You didn't have that topic?
No.
What? It's an important topic, so you'll read about it. Infertility is for both men. Actually, the chances of both sides is usually that both sides is equal. And there are many problems that can be in the man, and there are many problems can also be in the woman. Even when you're doing semen analysis, we're able to examine the semen, and there's a whole topic. It's a very important topic. In fact, I have to discuss with your teacher, because that's a topic that should not be missed out in clinical chemistry. And you do exams, and then this is where you even learn about IVF. It's in infertility, where you look at in IVF, so you know how you harvest the egg, then you have the sperm, then you put them in a petri dish, then you see when they have now the different methods. There are different methods of IVF. Hey, that's a topic you guys missed. It's a serious topic. You have to read about it. So infertility, the definition I gave is for both sexes. Yes, it's both. Okay, so we have infertility, then you have dyspareunia. This is the triad I said, what they present with, and dysmenorrhea. Dyspareunia is painful sex, dysmenorrhea is painful menstruation. So many times they'll present with that, okay? And then they have pelvic pain, especially if the endometriosis is in the pelvis, in organs in the pelvis. So usually, when you have endometriosis, you'll bleed from that area. You see the endometrium has a cyclic normal menstruation. So they have periods, monthly periods. So even where the tissue is located, say it's located in the pelvis, you'll also bleed the same way. Okay, so when you bleed like that, it may cause adhesions. Okay, no phagocytosis, healing, TC, then you have adhesions. So they'll have pain, pelvic pain. Then you'll have menstrual disturbances, painful defecation, depending on whether it has been located there, dysuria, if the endometrial tissue is found in those areas. Okay, so those are some of the things that can occur. But the triad is those three: the infertility, the dyspareunia, and the dysmenorrhea. Okay, so that's a very important part. Then sites, you'll have different areas being affected, the commonest being in the pelvis, within the pelvis, like in the ovaries, in the pouch of Douglas, in the ligaments, uterine ligaments, in the fallopian tubes, then rectovaginal septum. Okay, other places where you'll find them, like in the umbilicus, in the appendix, okay, in the colon. Okay, and then can also be found in the lung, by the way. I've seen a bit of umbilicus in practice, about maybe last year, maybe I probably saw like maybe 4 or 5. If they actually occur, okay? So those are the different sites. Okay. The clinical presentation of the pathogenesis for this endometriosis. So there are a couple of theories that have been proposed, okay? Theories, they'll use one of those the most have the metaplastic theory, we have the Mullerian remnant theory, we have the lymphatic or the vascular spread, then you have the immunological theory. So the most accepted is that retrograde, and I talk about it in one or two sentences and with a picture. Okay, so for the retrograde or regurgitation, it's just the menstrual flow flowing backwards through the tubes. Then it implants in the different areas, like in the ovary, etc. And I show you on this photo. So here we have our uterus nicely like that. Then now, normally, when you have your menses, they will come out like this through the vagina and out of the body. But now we are saying we are having retrograde. So instead of all of it getting out this way, it will go through the tubes like that and gets deposited in the ovaries or in the pelvis. It can even go to other sites like that. So this is the retrograde menstrual flow theory. Okay. At your level, I'll not ask you to tell me the molecular basis, all these immune things, addition molecules that are present to make it grow, or happen in the other areas. I'll not harass you on that. But this is just a diagram to help you understand it. Okay, the different sites. Because I know you'll ask, how comes there's no phagocytosis? Of course, there's an escape mechanism for them, how the cells will survive those areas. Okay, yeah. So this is how the retrograde is. Okay. So the other one I talked about is the metaplastic theory, Meyer's theory. Again, this one is just to do with embryogenesis. Like like you see where the endometrium is arising from. So you can have the mesothelium, the cells that line the pelvis or the abdomen, all coming from the Mullerian duct. So sometimes you'll see a rest of those at those areas as embryogenesis is going on. So you'll have growth of that endometrial tissue in those areas. Then the vascular is just like metastasis that we did for tumors. So you may have some of the menstrual different sites. And this is very important. It explains why you'll find it in the lungs. You remember the sites I mentioned, like in distant sites where you will find it in the lung or find it in the heart. Okay. The most method that explains that is the lymphatic and vascular spread theory. Okay. Then immunological theory is just a defective immune clearance. Your body is not able to clear the ectopic tissue. Okay, the ectopic endometrial tissue. Because I have summarized for your group. So you'll go and check and read more. But all those are theories that would lead to endometriosis. And this diagram just explains or tells us more of those theories. Okay. Of course, there's a bit of genetics, as you can see here in this lower circle. Okay. And all the others that I had mentioned. Genetic factors, as I mentioned earlier, I also mentioned. So we go to morphology. What do you see? What do you see? So there's a gross morphology and there's the histological morphology. Okay, what you see under the microscope. So usually you'll see the purplish red-blue appearances on the mucosa, like what I'm showing you on this diagram. If you look at this, this is a cyst. So we've opened up the cyst and we're looking at these areas. You see this one, which looks like reddish bluish. This is part of the endometriosis. If we cut this and look at it under the microscope, we'll see endometrial tissue. We'll see endometrial glands and stroma. Okay, so you see another nodule here. This is how they usually look on the mucosa. And another one here, this is how they look on the mucosa. And then if you have extensive disease, a disease that has been there for long, you'll have organized fibrosis. From this hemorrhage, etc., you'll have healing with fibrosis. Okay, and those ones can cause adhesions, like between tubes, which now causes like even the infertility, and have those occurring in ovaries or even obliterating the pouch of Douglas. Okay, so those can occur. In the ovary, we see them as chocolate cyst or what we call endometriomas. And I show you a photo of that. Oh, this is before we go to the ovary. Okay, this is in the uterus. You can see the ovarian tube, the ovaries. This is the fallopian tubes. Then you see the implantation, these two small ones. These dark clotted areas. This is endometriosis. This is a blown up image of the same, of this one. So you can see them nicely here. Yeah, this one's. So sometimes when you're trying to manage them, I think I had mentioned that a small choir are seen here just under the serosa of the posterior uterus in the pouch of Douglas. Yeah, we've seen that here, this ones. Such areas of endometriosis can be seen and obliterated using cauterization, burning. You use a dermal, then you just cauterize these ones like that. So in part of management, part of the different ways that you can manage endometriosis. This is a chocolate cyst. You can see here is a whole cyst within the ovary. Inside it has, blood. So that's why we're calling it. It looks like chocolate cyst. It's filled with blood. Okay, which is a very typical way of presentation of this endometriomas in the ovary or the chocolate cysts. It's a common way that it presents. Okay, so when you take this tissue and look at it under the microscope, this is what you will see. You will see here endometrial tissue. Okay, and if it has stayed for long, you see fibrosis. So you have to see that. For diagnosis, you have to see endometrial glands and endometrial stroma. Sometimes hemosiderin-laden macrophages, because now it sheds, so it bleeds. So you'll see the macrophages which have a hemosiderin ion, okay, stored ion. Okay, repeated hemorrhage will now cause fibrosis. Healing with fibrosis, like we can see in this diagram. Okay, like these are the intestines, as you can see here, using endometrial glands. Okay, this is another foci of endometrial glands like that. So that's what we call endometriosis. So you have to see that to call it endometriosis. That's the diagnosis. Okay, that's the diagnosis. Okay, so as I said, diagnosis, gold standard is laparoscopy with biopsy. So they do a laparoscope, then they pick where the lesions are, then they give us as biopsy, those tissues that they cut off. Then us, we look at the tissue and we see endometrial tissue, endometrial glands and stroma, and then we say it's endometriosis on that side. Okay, yeah. Then imaging they can also do for ultrasound, where they'll see like endometriomas in the ovaries. Okay. Okay, Mariah, again, they say is useful for deep infiltrating endometriosis. I don't think it's being done that often, but yes, it can be done. Another tumor marker, you may do CA125, which is usually increased, but again, I say CA125, I think you did in your clinical chemistry. CA125 is a screening thing. It's not good for screening. We use it actually for monitoring and staging of CA ovary, because CA125 will be elevated even in benign lesions. Like now here, endometriosis will elevate your CA125, especially things which are of Mullerian origin. You remember this one, we said it's Mullerian origin. So anything Mullerian origin will cause elevation of CA125. Okay, yeah. Sometimes they also test for antibodies, anti-endometrial antibodies, to see whether they are there. Okay. So general management, I don't want to tackle management for endometriosis. It's detailed. There's a lot going on now about it because it's a very common thing. Nowadays, there's even a time there was a very big billboard there at Pangani when you're getting into Nairobi about endometriosis and, awareness. And I have seen many people who have infertility because of endometriosis. So it's a big thing that's being discussed everywhere, and there are many studies and things being done. So there's a form of medical management that they use using different drugs. Long time ago, they used to use, I think, danazole or something, but the different things of trying to control hormonal. They are just trying to, have a period where you reduce the hormonal things of high estrogens, etc. Okay, so you have more like progesterone. Okay, just to suppress growth of that endometrial tissue outside the uterus. Okay, so there are different methods that are being used. Surgically is a good thing. When you're able to locate where the endometriosis is, then you go in and excise and remove, do ablation or excision. Okay, and then if there are any adhesions that have occurred, you do adhesion lysis. You break down the adhesions. Okay. Yeah. Then if it's in the chocolate cyst in the ovary, you can remove that cyst. You do cystectomy. Okay. But the definitive treatment is using hysterectomy, but I don't know, that's, it's really, yeah, but people want children and everything. So we first use all these other methods, okay? Medical and surgical without removing the uterus. Then supportive, when you have to do fertility counseling, talk to them of how they can use assisted reproductive techniques, the IVF I was talking about, and psychological support, because these people have problems getting the babies. So that's something that you really need to do. Okay? Yeah. And that's the end for endometriosis. Any questions? I know I didn't manage it. HPV, Coach had raised your hand. Coach is asking, a friend was diagnosed with this endometriosis thing, and was told to conceive. How does conception help to stop the condition? Okay, let's first begin by saying we've seen people with endometriosis have infertility. They have a problem with getting children. But we would say the reason maybe I think that the doctor was telling them to try and have a child is just so that you reduce the hormonal part. Have like a break. During pregnancy, the menstrual part is stopped. So it's not like pregnancy will cure endometriosis. It can't, because we've defined what endometriosis is. It's tissue outside the uterus. So it will not. I think it's only having a break, such that when there's a pregnancy, you don't have the normal menstrual cycle. So these changes with the hormonal thing of the cycle of estrogen being released, etc. Because in pregnancy, you have more of progesterone being released. So it's like a break, okay? And because of that break, and you're not bleeding normally, then even the lesions, wherever they are found, the endometriosis, whether it is in the ovary, in the pouch of Douglas, etc., the lesions tend to shrink, if I could call it, because there's no the normal excitation from the hormones from the pituitary. Yeah. So it's just a break. It's not a healing. It's not a cure. You've looked at the different methods that you can use for treatment. So I think that could be the reasoning behind your friend's doctor's thoughts, Koech. Yeah. Okay, Timothy.
Yes, I have a question. I've seen CA125 and it's not specific because it can also be presented in ovarian, things like ovarian tumors. Do you have a marker which is specific for endometriosis?
No, we don't have a marker which is specific for endometriosis. I haven't come across any. I don't think we have any. You mean like the way we have CA125, those tumor markers?
Yes.
No. Sorry, go ahead.
Yeah. My question was just, is there one which is specific for endometriosis?
Yeah, there's none for endometriosis. I haven't come across any. Has anyone told you anything like that?
No, it's just that because we've been discussing and have said it's also elevated in other disorders. So I was thinking, what's the best way to do a differential diagnosis?
No. You don't use CA125 at all in endometriosis. It is in the ovarian carcinoma. Epithelial, not even divide ovarian tumors. So we don't use it. We don't use CA125 at all for these other things. We only use it for endometrial carcinoma. Remember, tumor markers are non-specific and not sensitive. The only specific tumor marker is prostatic specific antigen, PSA. And what I mean by specific is that it's coming just from the prostate. That's the part of specific. But sensitive, to tell you that someone has cancer of the prostate, it is not high. That's why we have different modalities of increasing that sensitivity for prostate, for PSA. So in the endometrium, and we are saying it will be elevated. Then I have said we use it for ovarian. You're seeing now that's another even organ. So it's not specific. Heard of another marker for endometriosis. Have you come across it? Yeah, there's none. Endometriosis, by the way, the gold standard is laparoscopy. I hope, the one I put for you there. But this year 125, I have been getting, I'll be preaching every day and teaching everyone that people should stop misusing tumor markers. So yes, it will not help you. It will be elevated, but it's not specific. So there's none. The gold standard is laparoscopy. Laparoscopy shows you, they usually see something like a powder burn. I think I wrote it, yes, visual powder burn, when they visualize the lesions. This one, they're able to visualize this. And when they see them, they'll give us for, diagnosis, which is histology, but they can also do cauterization of these lesions. So that's the only way we can do the diagnosis. C125 out.
Thank you so much.
Okay, karibu. I think you need to also repeat, at least in your chemistry, you were taught about tumor markers, Timothy?
No, we were not taught.
What?
Tumor markers, we didn't cover tumor markers.
Oh my goodness, okay. There's a big problem. Okay, maybe the people will benefit. But when you're free, because we are doing chemical pathology or clinical chemistry for the MBCHB starting sometime in Feb. Maybe for interesting topics like infertility, I can share with your class rep the time. We'll be having, then if you're free, you can join in. Sometimes you have tutorials. You can just join in and where students present and we discuss, and you can just join the video free. Yeah, I think that's the best thing I can say for now. Okay, so yeah, I see many topics that have been missed out on the chemistry. I'll have to also discuss with your people about those topics for the other students. Oh, yeah. Okay. Then ectopic pregnancy, that is Mutuma asking, can ectopic pregnancy cause DUB when the zygote implants on the wrong side around the uterus, like close to the cervix, and starts growing? Okay, many times, okay, of course, first of all, DUB will happen. The normal cycle is hormones are released from the ovary, okay, pituitary ovary, and then excites the endometrium causes the bleeding and all. So usually, someone will come with a history for ectopic. They'll say, I have history of amenorrhea. Amenorrhea means they're not having periods. Then they've had amenorrhea for like 2 or 3 months. Then, or something like that, or 2 months. Then they come and say, now I'm bleeding. Usually it's because the cycle sometimes is also exciting the endometrium. So the fetus is implanted elsewhere, but there's a bit of bleeding that could occur on the endometrial wall. So usually we have to do a pregnancy test on those patients. When you do a pregnancy test and it's positive, we suspect an ectopic pregnancy. Now, where it's located, you can do an ultrasound, it shows you where it's located. But the commonest site is usually the tubes. So I don't know whether I wrote that. Yes, reproductive age, ectopic pregnancy. Yeah, it is. Can cause you have abnormal uterine bleeding. So Maurice, yes. Yeah, so I've been picking up a few of the gaps that your group is having. Yeah, so tumor markers not, infertility not covered, tumor markers not covered, so that I can send the message to your team so that they're able to have those covered, because those are important topics. I think like infertility also and tumor markers are important because you play a role, like even when you're doing those IVFs and everything. And then the drug, because when you're doing IVF, before we give IVF, we usually give the lady drugs, so that she can ovulate, to increase the chances of ovulation, so that we can harvest the egg. So we'll give those drugs, clomiphene, etc., and then we come in and harvest. So it's a team. We can't do without the pharmacists. So those are important topics. It's like endocrinology. Actually, it's part of endocrinology. Okay, because it's the axis that we are looking at. Okay, so it's a topic that I'll mention so that it's covered. And sorry about that. So let's look at adenomyosis. Again, as it was mentioned, adenomyosis is when you have endometrial glands and stroma deep within the myometrium. Okay, deep within the myometrium. I'd like to show you that. Sorry, I thought I had a photo, but let me just show you on the actual. Oh yeah. Okay, so here we are. So we are saying, see this light lining like this. So the endometrium is usually a light thing like this, very small. Usually when we measure, the thickness is usually about maybe 2 to 6 millimeters. Yes, up to 6 millimeters there about this lining like this. Then this one is a muscle, which is myometrium. So we are saying adenomyosis is when you find this endometrium, this thin one, deep inside. So you'll find it like here inside like this. That's what adenomyosis is. Okay, so when we find endometrial glands and stroma deep within the myometrium, that's what we mean. Okay, deep within the myometrium. Thought I had put a photo, but I see I don't have. Okay, so that's what we call it, deep within the myometrium. It occurs in about 20% of the disorders of the uterus. And how we pick it, the adenomyosis, is because patient comes with menorrhagia, heavy bleeding, very, very heavy. Sometimes they may have painful men. Okay, the common thing I see is menorrhagia, and I think I reported one the day before yesterday, an adenomyosis. Yeah, no, yeah, last week, the day before yesterday, I've been meetings. Tuesday I was in meetings the whole day. I think adenomyosis we see, so it's there. Okay, and gross morphology we also have those in the lab for how it looks. So morphologically, it looks like this. This diagram you're seeing, which looks like a sponge. You know, like when you cut a mattress, then you're looking at, this, what are these high density mattresses? Zile zenye zinatumika kutengeneza viti. Those ones. When you cut it, it looks like this. So this is how adenomyosis looks. You've cut. This is the uterus. This is the myometrium. Then the myometrium is like this. You see, like it has small holes. It's spongy, and usually it's global. If you put these ones together, it looks like a globe. It's globular. Okay. Forget about this. This one is a fibroid. This is a fibroid. You see, even it looks different. This white doesn't have holes. This one has holes, spongy-like. So that's how it usually looks. Okay, and many times it's thickening the whole myometrial wall, the whole uterus. Okay, then sometimes you may have a nodule which is separate, which you call an adenomyoma. I don't have a picture of that. This one that you're seeing here separate is a leiomyoma. It's a fibroid. Okay. I hope I wrote it here. Small whitish leiomyoma at the lower, this one. Okay. So microscopically, we want to see the deep-seated stroma and endometrial glands. Okay. Usually we count. It has to be away from the basalis. So this is how we count using the endometrium is here. So this is the normal endometrium is this one. This is how it usually looks. This proliferative phase. Then if you see here, this part, I can't call this adenomyosis because this is just close to the basalis. See, the basalis is the basement here. Basalis is here. So I look at those ones which are deeply seated. This is it. See, this the distance from here up to here. If I was to use the microscope, it's going to be more than 2 high power fields. It's deep within here. Or at least 2 to 3 millimeters from here to here. When I'm using my microscope, you measure like that. So this is adenomyosis. Because this looks exactly like this. It's just that this is deep. So that's what we call adenomyosis. Okay, so patients will present with heavy dysmenorrhea, pain in menses. They may have dyspareunia. They may have that. And then pain, particularly premenstrual period, just before the menses start. So diagnosis, again, you take the history here, you do pelvic exam. Ultrasound, they usually can pick, and this is how they record the ultrasound. But the definitive diagnosis is histology, okay, because we are able to see the cells. Again, as I've mentioned, the CA125 may be elevated, but again, it's not diagnostic, okay? Because all these are Müllerian origin, okay? Treatment, we give hormonal therapy, but the most successful is removing that uterus. You remove this one. You remove all of it. That's diagnostic. Or rather, that's the best treatment. Of course, you have to consider, is it someone has finished the, giving birth, you don't want more children, etc., for you to remove a whole uterus. So those are the different counseling things that you do before you remove the whole uterus. Yeah. Yeah, so we are about to finish now. We are going to endometrial hyperplasia, then we finish with the endometrial cancer, and then we finish with fibroids and cancer of the myometrium. I want to breathe in and out. So you allow me we breathe in and out for 5 minutes. So at 7:05, we come back. Eh? Faith or Timothy?
Yes.
Yes,
So we take a break for 5 minutes. Eh?
Yes.
Okay.
Okay. I want to breathe in and out. Okay, I'm back. Hello.
Hello.
Okay, let's finish. There are just a few slides left. Most of them are pictures. Can cause abnormal bleeding. We went into details of endometriosis and details of adenomyosis. Our cellular adaptation, our first topic in pathology, general pathology, we said hyperplasia is increased in number of cells. So we are seeing this now occurring in the endometrium. Okay. Endometrium has glands and stroma. So we're having more glands we're having more glands compared to the stroma. That's what we mean by that sentence. So we have an increased gland to stromal ratio, okay? And this is, of course, in comparison to the normal proliferative endometrium. From your histology, you know, we usually have proliferative endometrium, and then we have secretory endometrium. So now we are saying there's an increase in the number of glands compared to the proliferative endometrium. Of note is that this is a precursor to endometrial carcinoma, the type 1, which is called endometrioid. This we discussed in general pathology also. Now, the most important part here is that this endometrial hyperplasia is associated with prolonged exposure to estrogen. When the endometrium is exposed to a lot of estrogen, it undergoes increase in risk factors. Which are the different risk factors you think can cause this endometrial hyperplasia or increase estrogen levels in the body? Increased estrogen. Which different ones? So you've covered Nini. You've covered the ovary. Maurice, have you covered the ovary? Faith. Yeah, so there's some things you mentioned in the ovary. Mutuma Maurice tells me yes. You don't remember any? Okay, fine. But any other reasons why you can have prolonged estrogen in the body? Where can estrogen come from? It can be exogenous or endogenous, within or outside. You don't know any? You guys are exhausted. Eh? Okay, fine. Let me just take you through. So the risk factors of the etiology, as I said, unopposed estrogen exposure. That's the most important thing. Could be endogenous when you have the anovulatory cycles on people with obesity. Then you have aromatization. When you have peripheral tissue, there's aromatization, it becomes estrogen. Eh? I know you've done that in chemistry, biochemistry, so I'll not discuss it. Exogenous is when you have like hormone replacement therapy, where you're using just estrogen only for hormone replacement. Like when you give tamoxifen therapy, you know, it has more estrogen, you know? Yeah. Or other methods that can cause is estrogen secreting ovarian tumors. Commonest is your granulosa cell tumor. That's what I was asking. You've not done the ovary? Must have covered granulosa cell tumor. This is estrogen, and this estrogen can cause endometrial hyperplasia. Other things you've covered is like PCOS, polycystic ovarian syndrome, which has high levels of estrogen, obesity, which will lead to peripheral aromatization of the adipose of estrogen compared to progesterone, early menarche, so you have early menses when you get menses, and late menopause, so you have a higher duration of estrogen in your lifetime because you had early menarche and late menopause. Then diabetes. Okay, diabetes is related to all that. Hypertension, those are risk factors, cycles. And then family history of endometrial carcinoma can also be a risk factor. Okay. Pathogenesis, again, as I said, is high estrogen stimulation without opposition from progesterone, which now leads to the increase in glandular proliferation. There's reduced apoptosis or programmed cell death. And then the glands now grow and crowd together. Okay. Molecular events that have been mentioned with it. Early event is a PTEN mutation, and sometimes microsatellite instability may be mentioned. So progression, risk highest in the lesions which are atypical. I'll show you the WHO classification of the hyperplasia. So for the atypical side, there are chances that they'll become cancer. And this is a WHO classification. So there is hyperplasia without atypia, and then there's hyperplasia with atypia. Okay, with atypia. So the one without atypia, the glands are dilated. If you look here, this first one, you see the glands are dilated. There are many, many together like this, especially this one. Then they are cystically dilated, as you can see here. If we went to high power, you'll notice that there's no nuclear atypia or very minimal. Okay, this is how they will look. Okay, then with atypia, there's marked crowding. You see, like if you look at the D here, the glands are now too complex. They're so close to each other. They're complex. If you look at this D, you can't compare it with the A. Or if you look at the C, you can't still compare it with the A or even with the B. Okay, so and then they have cytological atypia, where the nucleus is enlarged. If you looked here, and then hyperchromatic. And if you went to high power, you'll see when it has nucleoli. Okay, so this is considered a premalignant lesion, the one which is with atypia. So we usually say classified using the WHO. My gynae will be very worried when I send him a report and say hyperplasia with atypia, because many times they'll just remove that uterus if I say there's atypia, because you don't know whether there's invasion when they say there's atypia. So clinically, these patients will present with abnormal uterine bleeding, as we said earlier. In the menses had waiting for AUB, so you'll do like an ultrasound, then you'll notice that there's the endometrium is thickened more. Okay, so complications that it can progress and become endometrial carcinomas, as I said. Then because of the bleeding, they may become anemic. Pelvic ultrasound, I've talked about it in diagnosis, where you have a thickened endometrium. Then definitive diagnosis, always. So you have to take a biopsy, endometrial biopsy. So there are different ways of getting endometrial biopsy. Could be a dilatation and curettage. It could be hysteroscopy, where they put a scope and then they take a biopsy. And then for definitive diagnosis is histology of that biopsy, because it is going to either take hyperplasia without atypia or hyperplasia with atypia. We will see like this, the biopsy taken, or whichever method. Whether they did a DNC, I thought I had a photo. I'll show you how you do a curating in a few minutes. Okay, so that's what we do for diagnosis. Again, as I said, if I write with atypia, many times they'll just remove the whole uterus. And because I've said the complication for the endometrial hyperplasia is endometrial carcinoma, so we go to endometrial carcinoma. And so that we have two more, we finish. Again, this is a malignant tumor of the endometrial epithelium. Okay. It's common in postmenopausal women. And because they cause abnormal postmenopausal bleeding, early detection and cures are very possible. And they happen. I repeat, postmenopausal, it means their periods ended. You know, postmenopausal, the average age for Kenyan population for menopause is 52 years, but it can start from 45 all the way to 55, but I was saying the mean. So if you have someone who is 50 years old and they'll tell you, maybe my periods ended like 2 years ago. So they have been, then now they come and, you know, and all that. Hey, so they will get very shocked, and so they will come to the hospital. Early presentation, because they are bleeding at postmenopause. So that's what I mean by that blue bullet. So we have type 1 and type 2. Okay, yeah. These are risk factors. Again, okay, so you just read that your own free. Types we classify as type 1 and type 2. So for type 1, the age group that is more common is 55 to 65 years. And then for type 2 is older. 65 to 75. Clinically, you will have mainly the type 1 is because of endometrial hyperplasia. So there are all those things of unopposed estrogen that we talked about. For the type 2 is usually anatrophic, is coming from endometrium, which is atrophic. Okay, so they'll not be obese, those patients. Many times they have a thin physique. Okay, but for the type 2, poorly differentiated mixed Mullerian carcinomas, funny things like those. Then the precursor, usually for type 1, is hyperplasia, as I mentioned, while type 2 is anatrophic endometrium. Molecular genetics, P10 has been associated with endometrial carcinoma, type 1, while P53 tumor suppressor gene and aneuploidies for type 2. Behavior, for type 1, it's indolence, okay? It's not aggressive nipple. It's very aggressive. By the time we're even going for diagnosis, it has already spread. It has a very bad prognosis. I've seen a couple of patients with that. Yeah. In fact, I remember one that I ever did, and I called it a clear cell. The surgeon did not believe, but I don't know where they disappeared to. They asked for the block. They wanted to go for second opinion, but they never reported back to me to know, whether they found a different diagnosis or not. But we see a bit of that. So the morphology, this is what you see. You look at the photos on this side. So this here, you remember, this is the cervix down here. This is the endocervical cavity. Then you go to the endometrial cavity. You can see a mass. Okay, so it comes out as a polypoid mass inside the uterine cavity, as you can see here. Okay, yeah. So for the sometimes could be friable, okay? And you might see sometimes grossly that it's invading into the myometrium. This is the myometrium. Okay. This is the polypoid endometrial mass. So see, okay, the cells are back, the glands are back to back. This is the lesion. Okay, this is the lesion. Okay, yeah. So there are different ones. So endometrioid type 1. Serous is type 2. I have a picture for that in here. This is a serous type. Again, this is the uterus. If you touch this side and this side, you'll join them back together. I just wanted to expose the lesion here, this one. Okay? Yeah. So they're coming up from the atrophic uterus. They're bulky. You can see the way they're so bulky. If you compare with this one, then it's this small thing like this. But this other one is quite bulky. Okay. And then microscopically, they are bad. You can see this is a serous type. You can see even different mitosis and different bad-looking cells here. This is in a vessel as it's spreading to another side. Yeah. Clinical features, as I said, because it's postmenopausal bleeding, the first most important thing they will present to you with. And that's how you'll know. You need to do accurate so that you can find out what the problem is. Okay? Then sometimes they may have a watery blood-stained vaginal discharge or excess vaginal discharge. We call excess leukorrhea. In late stages, you can have pelvic pain if it has spread to other parts and tumor cachexia leading to, it will show you the thickness is more. But now the definitive diagnosis is curative. You take a biopsy. So biopsy. So I show you that. This is hysteroscopy, okay? So they've put a scope, then they are able to see, then they will remove this biopsy like this, okay? The scope shows them where the tumor is like that. So they take a biopsy from there. Curates, you make the os bigger, they dilate it, then they put these curates. A curate is like a spoon, inafanya krrr, inagwaruza. So it will come in and come out with those small pieces and bring to me. So we call it dilatation and curate. So these are a curate. This is hysteroscope. So you put a scope, then you pick where it is and you bring for it. The histology. Additional things is when you want to look at invasion or staging that you can use. Okay. So general treatment, Primary method, the best thing is to do a TAH BS, that is remove the whole uterus plus the tubes and the ovary, okay, or chemo, etc. Yeah, so for prognosis, the grade of the tumor, how deep it has gone, and histological type. Type 2, of course, is the worst, okay? Worst prognosis. Yeah, so this I was just showing you the curate. And I'm done with the myometrium. And I stop there and ask which myometrial disorder you know very much, known by everybody. Because now I have only 3 slides. Then, I've even mentioned it's fibroids. Hello, are you people there? Julius, have you ever seen a patient with fibroids?
Yes, the latest one, I think, had 64, a 52-year lady.
Ah, yes.
64 fibroids were removed.
Yes, I actually see that also on my desk. But I also get younger people who have fibroids and they want to have children, so we do myomectomy because depending on where, I'll show you how they are located. They can cause infertility also, by the way, yeah? Of the younger people, not the 64 again. Yes. So you people have seen fibroids, so that's what I'm discussing. Eh? Okay, so leiomyomas, which we call fibroids, again, these are on the myometrium, diseases of the myometrium. You see, I've gone in stages all the way now until now I'm in the myometrium. So they're most common benign tumors in females and are found in about 30 to 50% of women in the reproductive life. Some books will say 70%, up to 70%. And I'll say, me, when I used to do autopsies, cesareans, or rather, when I used to work in the maternity, I worked for quite like more than a year in maternity, and I loved it. And I'm telling you, for cesareans, I think by the time I was leaving, I think I'd done like 500. And you'll see small fibroids and you're doing those cesareans. There were quite many fibroids. So I can actually attest to this, that there are actually many in that life. I mean, of course, they'll be asymptomatic, especially the small ones. So the peak incidence is 30 to 50 years. There's a genetic influence. At least they're still doing studies on the same. I did not want to bring it here and confuse people. Then more frequent in the blacks than it is in the whites. Possibly estrogens and possibly oral contraceptives stimulate their growth. The estrogen stimulate growth of these leiomyomas. And at postmenopause, when the estrogen exposure is decreased, then they also shrink. Some of them shrink. Yeah? That's what they think. Okay? That's why they. Okay. So as I said, etiology not known. Estrogen and progesterone dependent growth. Okay. When you have high estrogens, it will grow. When you have progesterone, it also decreases. 12 mutation. There are many others. We are not discussing those today. Okay. As we said, growth is stimulated during pregnancy and regresses postmenopausal. Okay, we're not going to molecular. Okay, of that. So pathogenesis, there's proliferation of the smooth muscle cells in the myometrium, increased expression of the growth factors, especially your transforming growth factor beta, your insulin growth factor type 1, and then the epidermal growth factor. They get increased. Those are the ones that make the myometrium to proliferate further. Then hormonal receptor, okay, which will increase the size of the muscle, which becomes now the leiomyoma. Okay, this is just the proposed pathogenesis. Okay, again, I will not harass you on that. Let's look at the locations. Okay, so when you see people have fibroids, again, we're back to our nice, beautiful thing. So you're saying it's a disease of the myometrium. So we've moved from the endometrium, we are now here in the myometrium, this thing which is almost, let's say, orange in color. So there are different sites where you can find the fibroids. So you can have them at intramural, inside, like this is nice, inside the muscle. Submucosa is just pushing onto the endometrial. You see, this is the endometrium out here, then this is it. That's submucosal, just beneath the endometrium. Then you can have subserosal, which is just beneath the serosal. It's projecting like this out, this one. There's another subserosal. Then you can have the pedunculated one, like this one. It's a submucosal one, but it has a stalk, like a stem, this one here. Pedunculated ones can also be on the outside, not necessarily into the mucosa. So those are different locations of the fibroids on the uterus. By the way, you can also have inside the cervix. You can have an intracervical fibroid. I've seen that. Okay, so this is just showing you morphology. Multiple, by the way, it's not one. There are multiple like this. You can have tiny ones like this, can have big ones like this. You can see, as I said, they can come all this way. I think there's also one trying to form here. There are many like that. Okay, so they are well circumscribed, as you can see, very well circumscribed like this. White tumors, they're white. Then when you cut them like this one, you see a walling. A better view would have seen things going around like this. That's what we call a walling pattern. Okay, like this, going around like this. And as I said, there are multiple. Then when you see them microscopically, do we have a microscopic? Yeah, here. They're smooth muscle cells. These smooth muscle cells, microscopy, how they will look. Okay, look like a stream. Imagine a pita hivi, imekuja hivi, inakuja. Yeah, that's how they look like. Yeah. Okay. Then, so as I said, interlacing bundles of smooth muscle cells, minimal atypia, and low mitotic activity. They may have degenerative changes like hyaline deposition, cystic. They may have red degeneration, necrosis, calcification, etc. Those are other things that can occur to them. Okay. These are just risk factors, which I think I have mentioned elsewhere. So clinical presentation, many are asymptomatic. Of course, if it's tiny, symptoms will depend on the size and the number and where it's located. If it's like this one, it can cause heavy bleeding. If it's here and where this is where you wanted to implant the baby, then the baby can't implant because the fibroid will stop it. So you'll have infertility, Or if it was here, the tube, where the tube is going, this side and this side, there's no way the sperm is going to come and meet the ovum and fertilize here. It can't happen, you see. So it depends on the site and the location. But the commonest is menorrhagia, especially for the submucosal one, heavy bleeding, pelvic pain and pressure, dysmenorrhea, infertility. I've mentioned to implant it as for a few things, and it's been eliminated by the fibroid. Then urinary frequency, especially if it's pressing on the urinary bladder. You have a big swelling that is pressing on it, or if it's pressing on the rectum, you'll have constipation. So again, as I said, depends on the size, the number, and the location. Okay. Complications. Anemia is the first one. That's how I find my people. You should come there. One day you ask Mr. Kamau to show you fibroids there in the lab. Just there. First floor. You guys are in second floor. Just come to first floor. You will see the big buckets there waiting of heavy. Then infertility, I mentioned, pregnancy losses like miscarriage or preterm labor or malpresentation. Now that means the baby is supposed to be here. There's a way the baby presents in the head down and the buttocks are up, etc. So when you have a fibroid, it will make that presentation not to occur. That's what we mean by malpresentation. Then torsion, if it's a pedunculated, if it has a stalk, it can tie around the stalk and then you have torsion. There's no blood supply to the fibroid or degeneration. Now, rarely do they become leiomyosarcoma. In fact, it's less than 0.001. So this statement, in fact, when you're taking these notes, remove this bullet. Okay, it's there in books, but it's not in all books, but it's rarely, never ever. Many times it will hardly become malignant. Okay, so diagnosis, clinical, and then you do per abdomen, you'll find the enlarged uterus, okay, with fibroids. Imaging is the first line. You'll do an ultrasound and see the fibroid, okay? Observation, if there's no symptoms, there's nothing. But now if they have pain, dysmenorrhea, etc., you can give NSAIDs. If they're bleeding so much, you can give tranexamic acid. Then you can give different hormonal therapies that are being done there, especially the gonadotropin-releasing hormone analogs. These drugs, they're being given so that you can shrink it. You can shrink the fibroid before you do surgery. You go and removal of fibroids is called myomectomy. Okay, so when you want to do myomectomy, it's because you want to preserve fertility, then hysterectomy is the definitive treatment. You remove the whole uterus, okay? Or sometimes you'll find people supplying the fibroid, so the fibroid dies. That's the best way to describe it, for me to describe it. So there are different things they can do, but for me, take home message is those sites and the complications that you can get. It's just a summary of the things that I have mentioned, all of them. Okay. So the last part is leiomyosarcoma. Leiomyosarcoma is now the malignant part. This one has 3 slides. So leiomyosarcoma, I repeat, typically it arises de novo, meaning it's not coming from a pre-existing leiomyoma. It's just coming from those mesenchymal cells of the myometrium. It just comes like that, okay? And many times they're solitary. They're not multiple. So the fibroids are many, okay? And then it will come from the smooth muscles, as I said, of the myometrium. Then molecular alterations have been, like for pathogenesis, they think it's that they have complex karyotypes. We did karyotyping in hematology. Mutations that have been picked, like TP, tumor suppressor gene, P53, retinoblastoma gene, all those have been picked. What we need to know is that it's a highly aggressive tumor. It's like the type 2 endometrial carcinoma. This one is bad, leiomyosarcoma. Okay, so morphology, they're bulky. As I said, it's most times solitary. It's one, very bulky, and they infiltrate completely into the wall. Okay, and sometimes they can project into the uterine cavity. Okay, yeah. Sometimes they can masquerade as a large benign leiomyoma. You think it's a leiomyoma, it's a leiomyosarcoma. And many times they're soft, hemorrhagic, and necrotic. Okay. Microscopy, you'll see that tumor necrosis, cytologic atypia, and mitosis. I just reported 2 weeks ago. No. It was December. It was December. Yeah. So this is how they look. You see, I said it fills the whole cavity. Then you can see the way it is having hemorrhage. So that one of mine had a lot of necrosis. It was horrible. It was a bad one. Okay. Poorly circumscribed, as you can see, hemorrhagic areas. You can see here, there's a whole hemorrhagic area. This is necrosis there. Okay. So it has no walling pattern. If you compare this and our nice here, look at this. This beautiful, nice, no hemorrhage, no such things. Okay. This is how bad our leiomyosarcoma looks. Microscopically, as you can see here, there's necrosis right here in the middle. Yeah, and they're usually very many mitosis. Then tumor necrosis, as we see here. So they usually call it like a triad. Marked cytological atypia, high mitotic figure, and then tumor necrosis, which you can see in all this. Yeah. So this is the solitary lesion. This one like here. And then all the things I've talked about. And necrosis. Last part is presentation. Again, abnormal bleeding because of where it's present. Then a largely enlarging tumor in a postmenopausal person. So you become very suspicious when you see that, even on ultrasound. They may have pelvic pain, and if it has metastasized, you'll have diagnosis, as I said, is different. These 3 things in histopathology. Same thing here. In fact, they call it the Stanford criteria, the 3 things. It's a very aggressive bad tumor. And that's the end. Only one person disappeared. Okay. At the beginning, we were 30 something, we were 32. Then they all know. On a class attendance before we give you the exams, the end of term exam, yeah, we'll be strict on that because it's unfortunate that we'll sacrifice, and on your side there, your colleagues are not sacrificing and yet their parents and guardians are paying school fees. Anyway, forget about attendance. Tell me, you people are there, you have managed to wait, ask questions before you go and sleep. Okay. There's no one
Yes,
asking a question.
just
Yes,
a
Timothy.
comment. A comment.
Yes.
Yes. Yes, the class was good.
Oh, thank you. Because it's today you people are quiet. Thank you, Timothy. At least you are still there pushing me on. And there's a lady called Joy Charlotte. Okay, maybe she's dropped out already. Okay, no issues, no questions. At least I've picked that you have for two. But I'll share once we have prepared, because we teach chemical pathology or clinical chemistry in term 2, which starts in Feb. I can share with Faith. Faith can remind me. I share with her. Like the lecture schedule that you saw, the one we give you. We also give that for chemistry. Then you can just look at topics that can interest you, and maybe join the classes when you're having, if you're free. Okay, or tutorials. We try to make them physical. Okay, even lectures, because that's we have a room that we fight every day, so ni kubahatisha. Yeah, then it's easy to get rooms, so you can just join in, especially for things that interest you, like the infertility, the tumor markers. What else would be? The rest you must have covered. I think those are just the ones I've picked when we are discussing that I feel like there's a gap. I think diabetes you did, the different methods for diagnosing diabetes. Timothy?
That one we did. That one we did. We have done it, and we did under biochemistry and many other places. So that one we are well covered. We also done it under clinical farm.
Then that one is okay.
We are sorted on that one.
Oh, okay. Because I'm trying to see which other topics I remember on top of my head. For chemistry, the ones I've picked, like when we are doing our discussions where markers I've noticed. I mean, it's not for examination or anything. It's just the good to know. So I wish I had even picked this during December holidays, because I'll have done for you an online, just let you know. I can figure out when you're free. It's not an exam thing. Then when you're having your holidays, you can just ask, and I can do some virtual on those ones we've picked, or any other that you feel a gap. I'm willing to do it. So you'll just check and see. And I'm sure my colleagues are also willing. Yeah, any of us, we are okay. We can take it through. There's no problem. Timing is a problem, but we can squeeze, because it's not for exams. It's for you to have the knowledge. Okay, so we can call it a day. Sorry, I changed from yesterday because I had meetings back to back. Okay, so enjoy your
sacrifice.
Okay, thank you, Julius. Yes.
But don't focus for those who have not attended the class. Focus on us who have attended. So
that is true. That is so encouraging. It makes me now to stop having the bitterness. We were complaining about you people, but it is good. You see, of course, even because this I think are the main students that I find all the time. It is your group, I can tell. And nowadays, at least I'm saying, if you have a gap in something else that you want us to help you in, don't hesitate. Even though you'll be a handful of 10 people, you're the ones who need that knowledge. Just look for us. Just tell me, give Faith a list, or any of you have my number, give a list. I can discuss with my colleagues. It doesn't have to be now when we are busy. It can be any time. Okay? Because this is exchange of knowledge, which I think is very important. Yeah. Thank you very much. I'm happy. Okay then, Kaherini, have a good night.
You too.
Good night.